Okay, for acute complications of diabetes, for the exemplar or the concept today, it should really be just on DKA and nothing else. But since we're on this topic, let's review acute complications of diabetes. There are three. We have hypoglycemia, DKA, and HHS. Let's begin with hypoglycemia. This is just a review. You already know acute complications of diabetes. Let's start with the causes. So what will cause hypoglycemia? Give me examples.
Obesity, low blood sugar. Hypoglycemia. Insulin, you give the insulin. And it causes hypoglycemia.
Okay, so is it always just like that, or is it more like okay, so lack of food in relation to insulin, right? Could it also be from, let's say, the patient started an exercise regimen?
Yes.
Yeah, because exercise is the same as insulin, correct? So we've named some of the common causes of hypoglycemia. Others are, let's say you drank alcohol in the absence of a meal. Yes. You injected the wrong insulin.
Yeah.
What if you have acute kidney injury or ESKD? Yes. Okay, so those are all possible causes of hypoglycemia. Manifestations. Well, it depends. There are three levels of hypoglycemia. We have mild, moderate, and severe. So next three paragraphs illustrate or enumerate the signs and symptoms depending on the severity. So for mild, most people have these. Moderate have these manifestations, and then severe, usually the patient is already unconscious. However, patients or people tolerate hypoglycemia differently. As far as interventions go, the rule is you have to treat the patient according to their symptoms, not necessarily according to the level of the blood glucose. Are we clear? Because let's say you have a patient, for instance, in mild. Mild means the blood sugar is what? Less than 70, right? Let's say they're in 60. What would you do? The blood sugar is 60. Yeah, give them food, right? Right, fast-acting sugar or simple sugars. However, if the patient is unconscious with a blood sugar 60, are you gonna give those crackers? Are you gonna shove them, open their mouth, crack it open with a jack, and then shove your orange juice in there? Okay, so you have to treat them like a severe reaction. Does that make sense?
Yes.
Or what if, let's say, the patient has severe hypoglycemia? They're unconscious. I mean, the sugar is less than 40. Okay, let's say 30s, 20s, but they're awake talking to you. Okay, they said, and then here you are worried, and then you say, what are you, crazy? I don't feel anything. So are you necessarily going to give them glucagon, IM, or IV dextrose? They're awake. So can you feed them?
Yeah.
I would do that. Okay, so did I make my point?
Yeah.
Treat according to the symptoms, okay, not necessarily the number. Are we clear?
Yeah.
All right. Of course, you can still treat according to the number, but use common sense. Meaning, don't force the food for mild hypoglycemia if the patient is lethargic or unconscious. You understand?
Mhm.
Okay. So this is what I mean. Always check the patient's blood glucose and correlate it with the symptoms. Here, sugar may be low, but the patient may not be exhibiting any symptoms. Okay, yes.
If the person's glucose level was 40, but they were
Uh-huh.
alert.
Yeah.
Like how long would it take before they became unalert? If unconscious, if.
Again, it depends for each patient. Like the lowest I've seen was 25, and here it is. Here's the old, 80-year-old talking to me, and the lab called, micro called, hey, your patient's sugar is 25. And I said, is that accurate? Here, talk to the patient. I gave the phone to the patient here. She's telling me your sugar is 25.
They didn't pass out.
So if hypoglycemia triggers adrenergic symptoms meaning they are sympathetic symptoms. Now, what are sympathetic symptoms again? High heart rate, vasoconstriction, right? What does that tell you about hypoglycemia? Is it minor or serious? It's serious. So it's serious enough to trigger sympathetic reaction. So of course, management starts with prevention. We should know, what are the causes, educate the diabetic, what could cause hypoglycemia, tell them about it. And then next, what else do you teach them? Signs and symptoms, correct? It can be difficult because let's say the patient's sugar is severe. Are they aware that their sugar is severely low? No, because they have mental status changes already, confusion, or they may be unconscious. Okay, so is this dangerous? Yes, can potentially be fatal. Patients can die from hypoglycemia. So prevention, that's why I emphasize prevention above all. Let's go to treatment. So here we are, the patient's already hypoglycemic. What's your action? Usual recommendation, again, unless the patient's already unconscious for mild, is 15 to 20 grams of fast-acting concentrated glucose. What does that mean? So these are unsweetened juice, okay? But again, here's a warning, no need to add sugar, okay? So it already has enough sugar in it. Unless, again, the patient's sugar is really low and they're awake, you prefer to add sugar there, you can do that. You can do that. So what's the treatment for mild? Okay, simple sugars, okay, like crackers, for instance, or juice would be great, okay, because it's already liquid, it'll immediately raise the patient's blood sugar. So, but the key is simple sugars, not complex carbs, okay, simple carbs. In moderate to severe, unconscious and unable to swallow, your options are glucagon, IM or sub-Q. Or if the patient has an IV access, you prefer to give dextrose. I prefer glucagon over dextrose because dextrose comes in a very big syringe, the 50 ml syringe, and I have to push that. It's hard. I have arthritis hands already. It's hard for me to push a 50 ml syringe. Okay, I go like this. Okay, I twist the plunger like again, it's a big syringe. That's how I give it. The problem with glucagon is it's a emergency hormone. What can emergency hormones like epinephrine, glucagon do? It will cause vasoconstriction, correct? So therefore, what happens to the peripheral circulation? It's gonna decrease. So what happens to GI Paracelsus? It's gonna slow. Can it trigger nausea, vomiting? Yes, that's the problem. So after giving glucagon, the patient may vomit. And what will happen if they vomit and they're still lethargic or unconscious? So what is your responsibility if you choose to give glucagon sub-Q or IM?
Aspiration.
Which is
You elevate the head of the bed, suction should be set up.
suction setup and elevate the head of the bed and head turn to the side. Okay. So prepare, okay? Because that can trigger nausea, vomiting. And should you feed the patient? So let's say they're already awake. You feed them you after giving glucagon. Again, only give them if they're no longer nauseous and fully awake. Okay. Because these interventions we're talking about, are they permanent solutions to hypoglycemia? What is the permanent solution? Like how are you guys not hypoglycemic? What did you do today? Eat. Okay. So as soon as the patient's okay, awake, feed them. What do I feed them now? Still simple sugars? No, a complex meal now. Okay, so, a full meal, right? So a combination of simple and then complex carbs, protein. Okay, so hold them longer. Nothing you can do. It's a happy class. Okay, they're happy over there. We have a boring class. So here's an option. You give it IV. If you don't have arthritis, or if you don't, you just like to give 50% dextrose. These interventions, these orders, the glucagon and the glucose gel or glucose tablets or the 50% dextrose are all automatically on your MAR with every diabetic receiving insulin. Okay, you don't need to call the doctor. You can call them later. Okay, so you have the interventions already ordered. So hypoglycemia, implement it, grab it, and then just tell the doctor the story later, unless the patient goes worse. Okay, because are you wasting time if you still talk to them?
Yeah.
Yeah, you're wasting time. This is an emergency, so you can't be, hey, yeah, patient's hypoglycemic, sugar like this, and what did you do? Nothing yet. You look like a idiot, right? So go take care of the patient. Get off the phone. Okay, so take care of the patient and then just tell them the story later. Document it so they can make adjustments also, because can this happen again?
Yeah.
Yeah, is it dangerous? Yes, so something needs to be done. Okay, so the doctor will investigate what happened. Maybe it requires adjustment, or maybe it was just a single isolated episode. Jennifer? Yes, they can go into seizure or coma, or both. So family members, in addition to the patient, maybe must be aware of the manifestation so that they can help. So what will happen if I have a patient whose sugar was 57 and I gave the simple carbs? 15 minutes later, I recheck, it's still 62. What do I do? Give more food. Okay, so you didn't give enough. Give more food, the same simple carbs until you reach 70. Okay, because 70 is normal. After 70, then okay, feed them a regular snack or food. But until then, you keep giving simple sugars, simple carbs. This is another complication that may increase the patient's risk for hypoglycemia when they're taking beta blockers. Because what will beta blockers do to the sympathetic response? It's going to suppress it. So therefore, will the hypoglycemic patient still manifest the adrenergic symptoms? You know, the sweating, the palpitations? No more. Is that dangerous? Yes, they could be hypoglycemic and they have no idea, which happens a lot in patients taking, in diabetics taking beta blockers. I'm a diabetic. I prefer to carry glucose tablets as opposed to candy. I have type 2. Gels, I don't like the taste, so I prefer glucose tablets. Because glucose tablets, they maintain their shape, no? And then unlike candy, where in the summer I can carry candy. It's just gonna be, what I'm doing is I'm already hypoglycemic and I'm doing this, okay? Because the candy is all melted.
Does that require a prescription, the glucose tablets, or?
No, you can buy that at the pharmacy. But yeah, the doctor can also write that and then you get it free. It's covered. But I mean, they're not expensive. That's it for hypoglycemia. Any questions? Okay, let's go now to DKA and HHS. DKA is one of two hyperglycemic problems. Still an acute complication. It's not as fatal as hypoglycemia, but will kill the patient nonetheless. The cause of death for in DKA is shock, hypovolemic shock. These are the main features. So the hyperglycemia, the number gets so high and the patient will have profound dehydration and electrolyte imbalances and severe acidosis. Let me explain this briefly. Remember osmotic diuresis? Okay, so in hyperglycemia, when the sugar is really high, the blood sugar is really high, what happens to osmosis? What will osmosis do? Where will fluid go?
Go from,
Concentration, so low concentration.
go from the cells into the.
From where to where? Water will move from where?
From the cell.
Low concentration to high concentration, right? So what's the concentration of the bloodstream if my sugar's like 300, 400, 500? Osmosis will move water out of the cells into the bloodstream. So my blood volume increases, correct?
Yeah.
And what will my kidneys naturally do? It's going to increase urinary output. So that will lead to dehydration and electrolyte loss. And if you remember in how hyperglycemia occurs, let's go to the illustration. There should be, okay, right here. So the problem in type 1, by the way, DKA happens in both type 1 and type 2. Used to be only type 1, not anymore. Even type 2s can have DKA now. So the problem here is, let's say it's type 1. They have no insulin, correct? Okay, so what's the only way sugar enters the cell? Insulin. The patients who get DKA are two groups. Either one group, they're known diabetics. They either didn't comply with the therapy or they didn't get to. Meaning, let's say they were busy or, let's say they were held hostage so they can get me insulin, but they have a gun to the head. Okay, that's an example. Or they had no idea that they were diabetic. This is the first time they're diagnosed with diabetes. They're finding out the hard way, which is probably they could die. So therefore, if there's no insulin, the sugar remains in the bloodstream, correct? But can the cells get to it? So what will the cells say to the brain? Give us sugar. We don't have any. We're hungry. The brain doing its job. Okay, let's turn glycogen into glucose. That's from the liver, correct? Okay, release glycogen into the bloodstream. Did that solve the problem? It made it worse. Now the cells are still saying, where's the sugar? We called you 20 minutes ago. Where is it? Okay, I'll bring you more. I'll break down fat. By so doing, changing fat into glucose leaves behind ketone bodies. This will lead to the ketoacidosis. Did that solve the problem? Made it worse, right? Finally, the cells are still saying, it's been an hour, man. Where's the sugar? I'll give you more. I'll send them over. I'll break down protein, turn it into glucose. By this time, what's happening to the blood glucose now? It was now 250. At the beginning, it was 250, 300. Now it's over 400, 500 now. Then the dehydration begins. Okay, so the patient now has osmotic diuresis, leading to, they're very thirsty, peeing like a horse. And then meanwhile, they're forming ketones. Manifestations again, acidosis is Kussmaul's respiration, correct? The increased respiratory rate. And then that will lead to severe ketoacidosis, can lead to seizures, coma, all right? So can this kill?
Yeah.
Yes, again, two causes of death. If shock doesn't kill the patient first, they'll die from severe acidosis. Okay, they could go into a seizure or a coma. So here are the causes as I mentioned earlier. So patients, either undiagnosed, or the more frequent one really is the patient got sick. What do you do when you're sick? Let's say you got COVID, you got the flu. Let's say the diabetic was not educated that let's say the diabetic believes that only food is the source of sugar. Right? Let's put it that scenario. So if that diabetic knows that or believes food is or beverage is the only source of sugar. If I'm not eating, what's my sugar? It must be low, right? That's what I believe because I didn't eat. I haven't been eating. No breakfast, no lunch, no dinner. It's been like this for days. I'm drinking a little bit. So meanwhile, is that really true? No, the sugar keeps rising and rising because remember, when you're sick, is cortisol being released? Yes, so that drives your sugar even more. So they stop. Meanwhile, they assume, oh, I'm not wasting my test strips. They're expensive. I know my sugar is low. Okay, I won't bother. I'm not eating. Meanwhile, this is what's happening now. Okay, the sugar is going high and higher and higher. And then they start to have the symptoms, the increased respiration, the Kussmaul's respiration, the acetone breath, and now they're unconscious now. Okay, or they have uh, the mental status changes. So prevention is next. So what should the diabetic be taught, especially when they're sick? Okay, when you're sick, sir, you should check your sugar actually more often because food and beverage is not the only source of sugar. So educate them how fat does it, how glycogen, how proteins can turn into sugar. Okay, so tell them our bodies are made of sugar. Okay, so even if you don't eat, it will continue to rise and they go, oh, is that it? My God, I almost died. Okay, so you educate them. So if they're not eating, they're sick, but their sugars are high, continue to treat it. Okay? Continue to treat it because it's high. Okay, don't worry, you're made of sugar. And then tell them this, the rest of it. If you can no longer, you can no longer stay home, you can't keep anything down, you've been vomiting, you can't even liquid, you can't drink Lucerna anymore, go to the hospital. All right? It's time to get help. Yes.
I have a question regarding DKA. If a diabetic was trying to lose weight and they were doing a diet that was a keto diet, which obviously puts your body in ketosis, is that dangerous? Is that specific
Very, yeah.
dangerous for a
Diabetic.
diabetic?
Mhm. They should not be doing that without the supervision of a physician. I mean, they can, we can't stop them, but they should really be consulting with a physician because it's dangerous. The way we do diet with diabetics is always subtle, slow, not not drastic diets like that. It's just not doesn't work well with a diabetic. So here are again a summary. So this is chart 46-9. Okay, so it tells you how often they check, what to do, including staying hydrated and when to finally call the hospital. Right? So nicely put chart. Manifestations, well, manifestations of hyperglycemia. I won't repeat that. The 3 P's, right? We got polyuria, polyphagia. Okay. Then don't forget because DKA causes acidosis, so there will be Kussmaul's respiration. And what's the breath gonna smell like? Acetone or fruity. Some of them maybe, let's say it happens when they were driving. They can actually be suspected of drinking. And of course, before they go to jail, they go to the ER, right? So the cops will stay there, and then the doctors will tell them, "Oh, it wasn't alcohol; it was DKA." Then they'll leave you alone. So in DKA, sugar starts at 250. You're officially in DKA at 250. However, it doesn't mean it will stay at 250. So it depends on how long did you go before you got treatment. So it can go higher. I know it says here 800, but there's really no limit. This can reach 1,000. This can reach 1,500. At that point, I don't know if you're alive though, but in DKA, the official diagnosis begins at around 250. Okay, for a type 1 diabetic. Like I said, this is also in type 2. This can also occur in type 2. But the main feature in DKA is really the acidosis. If you go back up here, what are the 3 key main features of DKA? No, up here, under the bullets. Okay, so hyperglycemia, acidosis, and dehydration. So if you have all 3, then you're in DKA. So in HHS, the first 2 will appear. No acidosis in HHS. Are we clear? Okay. So lab-wise, we'll look at the labs shortly, and then this will be part of your exam question to identify between DKA and HHS, okay? And for HHS, we will also teach the patient the same. We will teach them about sick day rules, okay? Because the cause is the same. The type 2 diabetic, because HHS will only occur in type 2s. Let's go to management now. So which is more important, the hyperglycemia or the dehydration? ABC first, right? Airway, breathing, circulation first. The patient's blood pressure here will be very low. They're going into shock. So what will you give first? Fluids first. What type of fluid? Why isotonic? Okay, because this will increase blood pressure. We need blood pressure to be high. So this will be hung first. Patient may need as much as 6 to 10 liters of fluid, depending on how long again. The onset of DKA is fast, can occur within hours. Unlike HHS, wherein it'll take up to a week to develop HHS. So 3 days to a week. In DKA, it's just a matter of hours. You could be fine before our break earlier, and then by the time this class ends, you're already in DKA. Is that fast? So we give lots of fluids. That's what you'll hang first. Doctor will usually give an order for 1 liter over an hour, or maybe 2 liters in an hour, depending again on how low your blood pressure is. So here's the rate: 0.5 to 1 liter for the first 2 to 4 hours, and then we can go depending on that. After that, so we discussed this in week 1. So now the blood pressure is at least over 90 now, systolic. So what fluid do we give next now? The cells are very dehydrated. Hypotonic now. So here, see, half strength normal saline will be hung next once the blood pressure is already stable. After that, the fluids, usually we can change. So right here on the end of the last statement of the first paragraph, it says here, when the sugar reaches 300 or less, DKA is considered resolved. So we can now switch to D5 water. Okay, so we give them, it's still isotonic, right? But we give them a little sugar because the patient will be, I'll show you next that we're gonna give the patient insulin also. But let's just finish this. So you monitor fluids, make sure you don't give too much either. Restoring electrolytes. Now I'll come back to this because the it'll be a little confusing if we do this before doing insulin first. So let's drop insulin first, and then we'll explain why there will be electrolyte problems. Okay, so reversing acidosis. So what caused the ketoacidosis? The lack of insulin, correct? Yeah, so because the sugar's high, why is the sugar's high? Because there was no insulin. So therefore, in order to stop the ketone formation, you have to give insulin. We can't give insulin sub-Q anymore. It's not going to work. So we have to give it IV. The only insulin you can give IV is regular insulin. So we will give this. We will give the patient 2 insulins. One is a bolus. So the bolus might be 0.1 units per kilogram. So let's say I weigh 70 kilograms. So how much will you give me? The order is 0.1 units per kilogram. I'll get 7 units. IV or sub-Q? IV. Now, how you give insulin IV? You've seen insulin syringes. Can you break off that needle? It's attached, correct? So how do you give it IV? How? Where's the normal saline? Into a bag? That means I have to consume all that bag in order to get that 7. Does the needle fit in a Luer lock port? Again, that's spiked into the bag. That's not what it said. It says it's a bolus. You have to give it IV directly. It's a push. So how do you push it? You have to transfer it to a flush. So grab a saline flush, add your insulin in there. So now you have insulin in the flush. Can you give it IV now? Yes, you can. So that's how we give the bolus. Next will be right here. Next part is, so we gave the bolus, right? Now we're going to give it slowly, continuous rate. 5 units per hour, depending on the order. So I'll give you a math question. So let's say my order is similar, 0.1 units per kilogram per hour. And then the bag is labeled 250 units of insulin in 250 mLs of NS. So how many mLs per hour will you run the insulin? I weigh 70 kilograms. The order is 0.1 units per kilogram per hour. The bag that the pharmacy sent you is labeled regular insulin, 250 units in a 250 ml bag. So what's the concentration of that bag? If you 1 to 1, right? 1 unit per 1 ml. So you hang that, just like we hung blood earlier. You hang that, you spike it, then you put it on the pump. What will you put on the rate? That's what we're doing here, right? Yeah. Just put it on paper or on the computer. But that's what you're doing. You get a pump. You hang that bag of insulin. It's labeled 250 units in 250 ml of saline. Spike it with a IV tubing. Prime it. Put it on the pump. Now, you're going to program the pump to do what? So how many mLs per hour will be the rate?
1.7.
So what's your answer? 7 mLs per hour. You'll explain later, okay? All right, we have time. So the answer is 7 mLs per hour. Now, don't think that the saline is running and then you wait for the saline to finish before you start the insulin. No, you hang the first bag of saline, right? So the patient has an IV, you hang it, spike it, okay, put it on the pump, you just press start, running 999 ml per hour. Then you grab the insulin. So it's just a few seconds between when you hung the saline. Of course, the textbook can't do that. The textbook has to do it by paragraph, but no, that's not actually how it's implemented. So yes, you hang the fluid first because this is the more important, right? Rehydration right here. That's what you give first. Saline. Then, right after you press start, saline's running, don't grab your insulin. Hey, prepare it, calculate it. Okay, I'm giving 7 units. Draw it, put it into the flush it. All right. And then you prepare the bag again. So a few seconds later, after giving the insulin bolus, now you're hanging the insulin infusion. You understand? So this is fast. Okay. Otherwise, this patient will die. So yes, we prioritize the fluids because the patient will be very and hypotensive, correct, at the same time. And then now we have to stop the acidosis. Without insulin, it will never stop. The patient's body will continue to break down fat. Okay, so you have to stop it by giving insulin. Okay, and then of course, after the, let's say the doctor only ordered 1 bag of saline, and then the blood pressure was already over 90, then we switch to what fluid again? The half normal. Okay. So therefore, in reality, if you were going to do this in a sequence, what really happened? Saline, insulin bolus, insulin infusion, and then as soon as the first bag of saline is done, switch to half normal saline. And then later, several hours later, the sugar now reaches 300. What do we switch to? D5 water. Okay, you understand?
Yeah.
You follow the sequence?
One way.
Do you understand why though?
Yeah.
Well, it's not really. It's quite simple, and it's exactly like this every time. Every time you have a
Saline first, then normal saline, then the bolus.
yeah, bolus insulin, and then the infusion. No, infusion first. Yeah, yeah, half normal once the saline bag is finished. Because let's say I started at 1 o'clock. It'll take 1 hour, so I won't hang the half normal until 2 o'clock. So meanwhile, what do? Just do this? No, I have to start the insulin. Okay, insulin's given. That's 103 maybe. And then I hung the insulin infusion at 104. Right, and then that's it. So I'm watching the patient. Then I usually get an order for Foley because this is a critical patient, right? I need to know, is my fluids enough? How do I know I'm giving enough fluids? The urine output. Okay, so how do I know this patient's unconscious? Will they get up and I need a urinal? No, you have to put in a Foley. Right, so now I have a hourly urine output. Okay, so I report to the doctor. Do I have enough urine output? Let's say after the saline bag. Doctor, nothing came out. I have no urine. Okay, so give another normal saline bag. You get what I'm saying?
Yeah.
Okay, so the therapy depends on how is the patient tolerating it? Are we giving enough? As far as signs and symptoms, so what will the labs show? This is a dehydrated patient. What will happen to the urine, BU and creatinine? What will happen to the H&H? Hemoglobin, hematocrit. So same thing as week 1, okay? Dehydrated patient. Simple, right? We're just using different examples, but same concept. So we did the reversing acidosis using regular insulin. Thought I was gonna be mugged. Okay. Now, regarding bicarbonate in 16. Okay, because there's acidosis, remember? Okay. So here it tells you when we say bicarbonate infusion, it's only given. Look at this statement. In general, where's the in general here? Okay. So what does that say? In general, bicarbonate infusion will be Okay, it's avoided. We don't really need to do that unless the pH is like less than 7 or even 7. That's really severe, right? Because normal pH is what? 7.35. Because the fact that you gave insulin, will there be further fat breakdown and ketone formation? No more. It's gonna stop. Therefore, is the insulin also treatment for the acidosis?
Yeah.
That's why it fell under the reversing acidosis intervention. You clear? So only give sodium bicarbonate IV if the patient's pH is really, really severe. Is severely like 7 or less. Then we have no choice. The patient will go into brain damage if you don't correct that. So you have to give bicarbonate infusion. However, if not, the insulin will take care of it. You follow? Louis? Yeah. Okay. So here, if you just read it, continuous insulin infusion is usually sufficient for reversal of DKA. Okay, does that help? Okay, again, just read the textbook. Okay, here's a rule when you hang the insulin. So this will come up, and I've seen this in ATI exams and also in some Kaplan. So this is when you prime an insulin bag, waste the first 50 ml of the fluid, meaning do you have 250 ml in the bag? Well, when the pharmacy sent it, yes, it was 250, but then you waste the 50. Why? Because it sticks to the surface of the tubing. So therefore, when you give the first 50, is the patient getting insulin? Not at all. Okay, so the insulin stuck to the tubing. So therefore, you have to waste the first 50, and then when you give it to the patient, then they get insulin. Because otherwise, you're running it. Imagine it was only running 7 ml per hour, right? So therefore, 7 ml per hour. If it's running like that, is the patient getting insulin for the next 7 hours? None whatsoever. You understand? Does that make sense? Okay, again, what this warning is saying is, I have the insulin bag. Okay, the 250 units in 250 ml. So I hung that right on the pole. I spiked it with the tubing, primed it. So when I prime, when the insulin goes through the tubing, the insulin sticks to the wall of the tubing. Only saline will go into the patient for the first 50 ml. So therefore, if I don't waste meaning I run it through the sink or the trash, I'm gonna waste 50 ml worth because the patient won't get any insulin for the first 50 ml because again, it will stick to the wall of the tubing. So I have to waste it. So therefore, when I finally connect it to the patient, will the patient still get saline only or insulin with saline? Insulin and saline. Because otherwise, if you let it run right away without wasting for the first 7 hours, because 7 ml per hour times 7 is 49 ml, right? So therefore, for the first 7 hours, are you giving any insulin to the patient? No. And then every time you check the sugar every 15 minutes, why is this sugar still 800, still 790? Because I didn't waste it, so I wasn't giving any insulin. Make sense? All right. Okay, let's go now to the DKA management. I mean HHS. Let's keep this one simple. The only difference between DKA and HHS is first of all, the causes are the same. Patient got sick, didn't check the sugar. The only difference is, since this is HHS, not DKA, is there acidosis in HHS? No acidosis. So therefore, is there fat breakdown? No fat breakdown. And how long did I say this thing will develop?
Well, daily, so-
Several days. So if it takes several days compared to DKA, which occurred within hours, and the patient was severely dehydrated still, correct? How much more HHS, wherein the patient was hyperglycemic for 3 days up to a week? Which of the two is more dehydrated? The DKA or the HHS patient? The HHS patient is actually more critical compared to the DKA. Plus, because there is no acidosis, will the HHS patient have any Kussmaul's respiration? What's their only manifestation therefore? And hyperglycemia will cause what manifestations? Drowsy. Okay, they feel drowsy and tired. Okay, so therefore, what will you do if you're drowsy and tired? I'll go to sleep. Okay, I'm not feeling too good. I'll go sleep. Will they ever wake up? That's the problem. They'll sleep forever. It's a peaceful way to die, but do you want to die? No. So here's the main difference. There is no ketosis, minimal or even absent. Most of the time it's absent. There is no ketosis. Because remember, in type 2, what's the problem? Is there absolutely no insulin? There is insulin, but there's also insulin resistance, right? So there's not enough insulin. So is there absolute absence of insulin that will cause fat breakdown? No, it does not happen. The problem again is the problem with this is the sugar goes high very slowly over several days, up to a week. And the patient just gets tired and tired, more and more tired. And then hopefully, we find out and we get them to the hospital. So when they come in, they're already in profound dehydration at this point because the dehydration is the same. I mean, the severity of the dehydration is commensurate with the level of the sugar, meaning the higher the blood sugar, the more dehydrated the patient becomes. Management wise, is it any different from DKA?
No.
Same. We will give fluids first, right? Do we give insulin also, bolus, and then the infusion? And then you also waste 50 ml? Same thing. The only difference is since there's no acidosis, will they ever receive bicarbonate? That's the only difference. Who's again more dehydrated? The HHS. So who will get more fluids? The HHS patients. Who will have who's likely to have the higher blood sugar between the two? HHS. HHS. We never give HHS bicarbonate because there's no acidosis. And in DKA, we said the statements there that said that insulin is enough to reverse acidosis. So I added something that we only give bicarbonate if the pH is really, really severe, 7 or less. Yeah, because at that level, you're causing brain damage already. That's the whole point of DKA. That's why it's called diabetic ketoacidosis, because there's ketoacidosis there. There's fat breakdown. Ketone bodies are causing the pH to drop. No. It's the level of the pH. Meaning, remember what caused the fat breakdown in the first place in DKA? No insulin. When you started giving the bolus and then the continuous infusion of insulin, is the fat breakdowns leading to ketone formation still going? No more, it will stop, correct? Because you're now giving insulin. So therefore, do you conclude that insulin infusion will stop the acidosis? Yes. Yep. Again, when the patient went to the hospital can vary. Okay, so let's say you got a homeless person in Kussmaul's respiration. but they have no insurance, right? So what are they likely to do? Go to the ER? Or maybe you have mental illness there too. A patient has mental illness going into DKA. Do you think they'll go to the hospital? No, it could be more than 24 hours before we got them there. So will the pH likely be 7 or less?
Yeah.
It could. So in that instance, will insulin be enough? We have to administer bicarbonate, right? Yeah, we just look at the basis will be the pH number. If it's 7 or less than 7, you have to give bicarbonate. So last table, 46-6, this is the side-by-side comparison for your DKA and HHS. Remember I said earlier, I'll ask you a question, what's the difference between the two? So this will be it. So this could be a drag and drop on your first exam. So you drag the lab findings under DKA or HHS.
And
Okay,
then
I'll base it on table 46-6.
what's for next week is
Dialysis, CKD, and a little bit of AKI until HHS. Quiz. CKD.